All right, thanks to you both. I want to take just a few minutes for what we were supposed to be talking about for the last half hour, but fortunately this was an interesting conversation. And that's some thoughts about some future directions and capacity building. I know it's a whole topic in itself. We've talked about what's needed to strengthen the fields of modeling, the data issues. We've talked about how to enhance communications, how to help decision makers use these models differently, how to capitalize on technology. So if folks have a few thoughts about how we build all those capacities, and that would be a great time. Say yes to all of those. It's late in the day. All right. Well, George, then it's yours to wrap up.
You have some thoughts on capacity?
Well, I sort of do think it's yes to all of those things. I think the kinds of things that, for instance, Rajiv was talking about, the capacity doesn't exist at local levels to do that with the skill sets. So we do need more people. We need to help them facilitate access to those data, those models. We clearly need communicators who can, and we need the skills to build those bridges. So this isn't just an academic exercise. I mean, I think there's a whole series of things here that we need. And as Mary was hinting at, there are technologies out there that should be able to help us get there. And at the same time, we've got to build the kinds of systems and incentives that Sandy was talking about that actually link the clinical care system and help the clinical care system deal more constructively with the community-based activities and policies that should drive not only health but some savings, and figuring out how to get those transfers will be really important. David, you have a comment?
Yeah, as long as nobody else came up. Dave Kindig. I mean, on capacity, I don't know the answer to that, and maybe we do need much more attention to it. I think it's clear there's a lot of dimensions that are needed. I mean, even at the research level, understanding the value, either the effectiveness or the cost effectiveness of interventions, so that those coefficients can be plugged into models that can get more and more reliable. I mean, that's an underinvested part of our academic and research world. So there's a role for government and the foundations, to step up there. I mean, it boggles my mind a little. So when I started this morning, I read that recommendation from IOM saying we need more modeling, but the recommendation actually says HNHS shall do this. And I've been sitting thinking, I don't know what is needed. I mean, we've got things already out there like Bobby's model and other models, that are not governmental, and they're used differently in different localities. And maybe if the evidence works, that can work, but is there also a future? Is this important enough? Our healthcare costs and our health outcomes are such a disgrace that there might evolve some sort of a national model like we use for econometrics or for the gross domestic product that really rise to a level that the Treasury or the Domestic Policy Council or somebody, or OMB would, drawing from CDC and ARC, and so I don't know. I mean, I think where that ought to be, but I think the challenge is such that both of those things are worthy of investment and further development in ways we haven't fully elaborated here.
Right.
Ray Baxter, Kaiser Permanente, and a member of the Roundtable. I think one of the issues that we need to give some thought to is the change in culture that is required in a whole lot of different professional areas to be able to accept modeling, understand how and for what it can be used, and embrace it. And I suspect that modeling also needs a PR agent. Bobby raised the issue this morning that you can't do all this stuff in your head. And Paskey and others in different ways referred to the complexity as well as the tools that we currently have that we didn't have in the past. But I think we continue to be up against whether it is individual clinicians, the profession of medicine, elected officials, anybody along the spectrum who's a potential user of modeling, that almost all of those people still do believe they can do it in their head, or that somehow it can be done by a group of people doing it in their head, using the best practice, reading the data on the trials, somehow that all of that can be integrated and done. And so the dilemmas that were put out early in the day around people either wanting to totally junk models because they have one flaw in them, or completely embrace them. This is a real challenge, I think, for us. And most of the people in this room are here because we're excited by models. We see the potential of how they can be used, or we have actually already seen that. But I think there's a challenge out there in a whole variety of professions where the understanding of how to use them is simply not there at this point, and it results in a kind of dismissal of models as black boxes. So.
Yeah, we see dismissal of even good science. For those of you who haven't read Merchants of Doubt, it's a sobering story about how people use scientific uncertainty as a lever for tobacco, acid rain, climate change, to act like there's a real debate when science is still compelling. John?
John Auerbach from CDC. Just building on that, what I think this is an important discussion to have in the context of the other discussions that are also taking place about what's foundational public health. Excuse me, let me turn off my phone. Foundational public health, and what should be part of core public health at the local, state, and federal level. I don't think modeling is, and I think what people need that are working at that level is assistance, technical assistance and support in terms of understanding how to do that kind of modeling. As you've talked about modeling, Bobby, for example, there are different kind of modelings. There's modeling like federal agencies may do that are at the larger level in terms of cost, some of the things that Darshak was talking about. But part of what we also have talked about is modeling as a community organizing tool, where it's very grassroots, the community's helping to shape that and add values to the models. And I think there's great potential there, but that really is something where there needs to be attention to how do you build those, the awareness that can work, the skills that are necessary, training, some sense of funding. I would say as an local state health local officer, I would say I wouldn't have a clue about where to find someone who had expertise in modeling at a local level. And so I might find someone who wasn't very good at it and might make for a very bad experience. And so I think people need real guidance in terms of how do you find someone who's good at that? How do you plug that into a community organizing process? How much does it cost? Some sense of where the division of labor needs in terms of providing the funding, the training, and the technical assistance. Some of that practical attention, I think, would be very helpful.
Great. Paskey?
Yeah, great. I can follow that up. So I don't want to present a centralized government approach to modeling versus the distributed community-based modeling approach, because the two go hand in hand. But I'm really resistant to the notion that the government should step in and solve our modeling problems. I'm going to introduce and define two kind of geeky words. One is scraping, one is parsing. So scraping is essentially, I write my code and the code goes out on the internet to the cloud, and if you describe, it follows on to my earlier comment, if you describe your data and structure it, I know where to go and find it, and I've written half a page of code that will go out, look for your data, scrape it, bring it down. The second part of that is parsing. You don't have to adopt the same organizational structure that I use, but then I can write very simple code that then organizes the data on my laptop, on my PC, the way that is useful to me. So I think that we don't necessarily need that centralized approach to data gathering and model making. If we just subscribe to the notion, describe your data, make it machine readable, put it out there, there's so much to be gained.
Great. Thank you, Paskey. Okay. Yeah, Mike?
Michael Weisberg, University of Pennsylvania. Just wanted to follow up on this recent discussion. So I'm the quintessential outsider here, but I am a modeler and I teach modeling. One of the things that other modeling communities have done in the last couple of years, which seems to be effective in communicating, is they've developed essentially a standard format for the presentation of a model that, so that even people who can't really understand or I shouldn't say can't understand, but who don't choose to take the time to understand the computational or the mathematical details, really have a sense of the assumptions in the model, the intended scope of the model, what data, if any, that it relies on, and so forth. And there's a standard, so in the sort of complex system social science literature, it's called, I think now of course it's not coming to be, Grimm and Railsback are some of the authors behind it, but there are these standard formats, and journals are starting to require them. So one thing that this group, the Roundtable, might want to think about is, given the needs of people making policy decisions or actually treating patients or thinking about public health, what are the kinds of things that you'd want to know on the input side, the output side, the design side, the scope side? And that could become a contribution that this group makes. And so then when someone's asking whether it's at the local level, is there some model that's out there that I can use, which the answer is typically yes, with adjustments, it's much more perspicuous. As anybody who's ever tried to borrow code knows, you can't really tell from just looking at code. On the other hand, if the model itself is structured in this sort of way, it can be quite useful. Just while I'm at the mic, the other thing that's come up earlier today, I hope it doesn't get lost in the record, is there's a lot of discussion about thinking about uncertainty going into the model and uncertainty coming out of the model, and the use of the model in supporting good decision making, and that one should think of models as tools for decision support. So I hope that becomes a continuing theme of this group if it continues.
Great, thank you. Yes.
Bob Griss with the Institute of Social Medicine and Community Health. It sounds like we're trying to reinvent community health planning, but we're using a tool, namely modeling, and losing sight of the stakeholders in community health planning and empowering them to act as a community. And it seems to me the government has a crucial role in ensuring that different actors in the system have input into the process. And I don't hear that in a lot of the modeling examples. It can be an empowering tool, but I really think that the government needs to be using regulatory authority to set standards that then the community has an opportunity, in fact, a requirement to meet. And the government has lots of leverage. It is the major payer in our healthcare system. And community benefit, which George Isham mentioned, has not been an effective tool in prevention or addressing the social determinants of health, or even in making the healthcare delivery system more efficient. I think the government's regulatory authority ought to be clarifying where those gaps exist, and then incentivizing the community to meet those standards. That's the kind of system that I think we need. To talk about modeling as a replacement for community health planning, I think is a fiction.
Great. Well, good. Interesting place to stop. So, George, I turn it back over to you.
So thank you very much, Steve. Really appreciate that conversation. And we're going to transition here as we close to some conversation that relates the topic of this workshop today to our larger purpose of addressing the improvement of population health across the country. And I particularly am looking for Roundtable members to do some analytic or context setting for this conversation, this day's conversation, in terms of how it relates to that larger purpose. So I'm looking for a little context and a little analytic and a little reflection at this point. But before I go there, I'll just make one transition comment from the last excellent conversation that Steve just moderated, and that's in terms of analytic In terms of the government policy toward the formation of accountable care organizations and the shift of payment models from fee-for-service to risk, one of the commonly identified capabilities that healthcare systems, and I'm not talking about health systems, but healthcare systems need, is often identified as information and analytics. And if you look very underneath that, very far, what you do find is a collection of these operational models, which actually have a long track record in some of the leading organizations, the Kaiser Permanentes of the world and HealthPartners. And I mentioned them in that last question that I asked you in terms of predictive models of cardiovascular risk at the point of care, using electronic medical record data, looking at the analysis of the distribution of preventive care in practice populations or insured populations. There's years, in fact, decades of experience using that. And so one question we should have is what those operational models, what they can teach us for the larger task of improving health in populations, and what they can teach us in terms of their use in broader communities than just healthcare systems. In addition to the fact that the ACA and those incentives will obviously spark the increase in that capability and the use of those models in care delivery going forward. So I just make that observation as a transition. So the floor is open for those observations, and I hope I've been long-winded enough to allow a few of you to be appropriately reflective. And I see that, Jim, that you have risen to the challenge. And I would like the rest of you in the room to notice the good example that Jim is setting by stepping forward and making this comment.
I always like to go early because my fellow colleagues always steal my ideas when I sit and wait to come late. So I don't have many good ideas. But it's interesting. I thought this was a very nicely structured workshop, and give kudos to the people who brought it together. I think we learned a lot in the beginning, and then we applied some of those learnings as the day went on, and forced ourselves to grapple with some really difficult and important real-life questions about using this. But I want to say one thing that I walk away sort of firmly feeling good about in some ways is that we know that one of our challenges in population health is the issue of evidence, and that whatever we do often takes a long time, or if you use normal research methods and normal ways of getting evidence, it would take a long time to show impact. And so I'm excited about all the work at coming up with models that will help us, perhaps simulate things and use other methods to help us sort of project into the future what might happen based on more current information. And so and I think in some ways there are problems with that, there are weaknesses, but we have to figure out how to make that happen, because it's probably the only way we can get the type of evidence we need to really come to decisions and to convince people to invest in this. So that's important. And I think that it is interesting, in our breakout group, it really became clear to me the difference between like presenting information in clear ways, and I think some of these models can do that, and increasingly I think people are getting used to thinking in these terms, but then you have to have some modicum of data and evidence that allows you to get to a convincing story to people who make these decisions. Thank you.
Thank you very much. I thought Kathy Bassey was going to come to the microphone there for a moment and answer the question of answer the question of how modeling might be useful to employers in terms of productivity and so forth. But she can think about that question while you make your comment, Mary Pippin.
I'm going to be very brief and say one of my takeaways from the day, besides I love seeing Rethink Health every time it comes out, it's just better and I think more refined. So I was glad that we had that tool here and Bobby to participate and now be part of the roundtable. But I think a comment that Nick made when he was reporting out from the breakout session, where he said we have to harmonize data to humanize it for policy, is an important, I think, theme that's run throughout the day in terms of, you can have a whole lot of data and not harmonize it, and it's chaos. You can have harmonized data and not know how to apply it in a way that it's really going to be a good source of input. It could be data that's not relevant to the policy you have, and don't forget to humanize it to get the community inputs and to make sure that we are taking into account the populations that we're trying to serve, both with the collection of this data and the policy goal that we have at the end. So that was my kind of, thanks to Nick, my phrase for the day.
Thank you very much, Mary. Kathy, thank you for rising to that inappropriate challenge that I gave you.
Thanks. Kathy Bazzi from Dow Chemical. I guess you were asking for context and reflection, so I'll bring that first, and then I'll answer your other question. This roundtable, as we've carried on over the last many meetings that we've had, have dove deep into many different areas, and then we've always said, oh, this has a lot of impact. We've looked at, equity issues and poverty and the built environment and health and all policies in the private sector. And we've looked at so many different factors at a very, focused way for each workshop, and how those really are critical to the intent of achievement of population health. And one question has continued to follow us through this whole time, and that's, how do we actually amalgamate all of this? How do we distill this to sort of the path forward? How does this come together at some point? And, each workshop gets us all excited about how important that subject is, and then we go to the next one and it's that subject is important. And one of my takeaways from today, and I do applaud the planning committee, I think it was very thought-provoking and fantastic speakers brought in, was really about how modeling is a vehicle or a tool that can help with some of that amalgamation and can help with some of that cross-cutting thinking. At least, particularly we saw that with Rethink, but even with some of the other models, it's that it helps us with one of the greatest challenges that we continue to debate in the roundtable is, how does the whole thing come together, and how do we create any plausible path forward out of all of the information? So that's my takeaway, is that modeling really is a tool, and it can be a tool to support decision making, and we've debated a lot about the merits of its perfection and imperfection, but I think it's a tool that's also useful for convening and for shared learning, in addition to just decision making. Not that I don't want to demean decision making, that's pretty important, but I think there's a secondary benefit of modeling that could help in the path forward. And as far as employers in the business sector, we use models all the time, and they're very effective. I think it would, and we've also talked about language, and how do you find that common language to get to various stakeholders? And I think modeling is a language that's very well understood in the private sector and would be very effective in that way.
So we should add that kind of modeling as, again, a topic on the list that we haven't fully explored here, that obviously might have some utility in terms of health at work and productivity and so forth. So, Ray?
So I want to first address how modeling may be able to help us with the roundtable, and then second, try to give another answer to your question about business and organizations. Just as modeling could be a vehicle to help us think through how to pull everything together, as Kathy said, and I think that would be extremely valuable. I think it also can help us with communication, because another theme that's gone throughout our deliberations is how much difficulty we continue to have explaining what population health is, what it's about, what drives it, what makes it move, so on and so forth. And I think one of the attributes of modeling is, as you go back into it and look at and understand the assumptions and also run things through it, it helps you understand how pulling one lever plays itself out in other ways. And that can be reduced to some, even though the model's complex, it can be reduced to some fairly simple and direct communication sometimes. So I think we should give some consideration to that. The second comment I was going to make to link modeling and employers, and I'll go any employer Doesn't have to be private business. It can be a government agency or whatever, but any sort of organization. I think that one of the things modeling can do around population health is help entities understand all the varied impacts they have on health by the way in which they do whatever their business is. We're in the middle right now of engaging in something at measuring what we call total health impact, which is what is all of the impact that Kaiser Permanente has wherever it is. I'm talking about the impact of pensions, employment, wages, toxics that are used in healthcare, our environment, the energy that we use, the water we use, fundamental issue in California right now. But thinking through all of the footprint that an entity has and the impacts of that, and then using modeling also to think about how does that actually play out in the health of the community where we're located or where any entity is. Not a simple task, way too hard to do in your head, but something that can be aided a lot, I think, by modeling and by building on some of the work that's been done. And in turn, that then creates a way for an organization to have a sense of what its stake is in health, even though it may think it has absolutely nothing to do with health or is only thinking about the health of its workforce or something like that. So just a couple thoughts.
Very thoughtful, and thank you, Ray, for those comments. And looks like this will be the last comment as we come to the closing minutes here of the workshop.
Yeah, Sandy Mackin from Minnesota. So I had looked at the objectives for what our workshop was supposed to accomplish, and it was about decision makers, using modeling for decision makers, which I think we heard today could be helpful in context. But I think we also heard it's not just treetops, it's grassroots, and how to think about modeling to create those conversations between treetops and grassroots so that we actually all own population health versus we just think policymakers are going to solve it. So I think that was just reinforced over and over again, especially when we broke out into small groups. Almost everyone said we needed to be empowering communities and engaging communities and entering them respectfully, and that just like an EHR is a tool, these models are a tool, and they will help us try to accomplish our goals, but they are not the end point in it. So that was just reinforced, that we need treetops and grassroots, and we need to think of tools as a way to engage conversations around population health.
Thank you so much, and really appreciate these comments in this section to help give a little context and be reflective. I think they give a very nice way to conclude this just wonderful day. It remains for me to thank Steve Teutsch, chair of the Planning Committee. Steve, you've done a wonderful job, and the Planning Committee that you've recruited and have been helping you do this, fabulous job. Thank you so much. Appreciate the time and the trouble that people have taken to travel to Washington, make their preparations, and help us understand and be educated and to learn more about this topic. So thank you all, those of you who've done that preparation. I appreciate the participation of all of you in the breakout sessions, in the questions, and being attentive and so forth. I especially appreciate the IOM staff, Alina, and all of the IOM staff, Alina Bachu. I can't see because of these lights if you're in the room here. These excellent discussions would not occur without their excellent and skilled preparation, interaction with the speakers, and helping us to shape this dialogue. So as we leave today, I think we've learned a great deal. I have learned a great deal, and it's stimulated a lot of thoughts, which I've not been shy about sharing through the day. You will be able to see this event on the website, I believe, in a week's time, at our URL, which is iom.edu/pophealthrt. And that will be available. We will produce a written summary of this workshop that will be available eventually. And I'd like to make sure that you have the opportunity to sign up for our listserv at the registration desk, or is there a way we can do that online too?
Yes, there's a
So there's a place to put in email addresses on the website too. So I would encourage all of those of you who have been interested and stimulated by this conversation to join our larger dialogue by participating through downloading those products, reading them, disseminating them, and joining us in terms of the listserv and other ways in terms of the conversation. So have I forgotten anything, Alina? We are adjourned. Thank you very much.